Hi everyone, today we are solving MCQs on medullary carcinoma of thyroid. Before solving questions, we need to know certain important things about medullary carcinoma of thyroid. So it constitutes of about 2% of all thyroid cancer. The cell of origin is from parafollicular C cell. It secretes calcitonin, which is used as a tumor marker. So 25% is only familial. So rest of the 75% of cases are sporadic. So when it comes to familial, so it is mainly caused by the mutation in red proto-oncogene, so which is found in chromosome number 10q11. Sporadic, you see it in 4th to 6th decades, and more 70% of patients present with cervical lymph node metastasis. So, the red proto-oncogene is responsible for MEN2A and MEN2B syndrome. MEN2A usually presents in 3rd decade as medullary carcinoma thyroid, and MEN2B in the slightly earlier in 2nd decade. So, elevated calcitonin can cause diarrhea, flushing and weight loss, but never it can cause hypocalcemia. So treatment is total thyroidectomy with central neck node dissection, and prophylactic lateral neck dissection is based on the calcitonin level. So advanced malignancy requires external beam radiotherapy to the neck and the mediastinum. So we'll start solving the questions. Screening method for medullary carcinoma of thyroid is they're asking for the tumor marker. The tumor marker is serum calcitonin. It is serum calcitonin. So treatment of medullary carcinoma thyroid, already told, it is surgery with central node dissection. So advanced cases might require external beam radiotherapy. So the first treatment of choice is surgery. The surgery consists of total thyroidectomy with central neck node dissection. The false statement about feature of MTC is, so familial MTC may present in 2nd decade. So this is a true statement. It has a characteristic amyloid stroma. Yes. It secretes serotonin. Yeah, it can secrete serotonin because at the higher levels you have calcitonin followed by CEA and even ACTH and somatostatin can be, and chromogranin are possibility. So secreting serotonin may not be at a significant rate, so you can take it as a false statement. And take up radioactive iodine, no, it is arising from the parafollicular C cell, not the follicular cells, so they do not take up radioactive iodine. So secretes calcitonin, this is true statement, so the options C and D are correct. So thyroid radioiodine ablation therapy is useful in all except. So radioiodine ablation therapy is useful if the cell is able to take up the iodine, and these tumor cells can concentrate iodine. So that is only possible in differentiated thyroid cancers such as papillary, follicular, Hurthle cell carcinomas, and not by medullary and anaplastic. So recurrent papillary carcinoma, yes. Residual papillary carcinoma, yes. Anaplastic, no. And follicular, yes. And medullary, no. So these two options are correct. Age for prophylactic thyroidectomy in MEN2B syndrome. So the age for MEN2B syndrome is 1 year. So the option is not given here. The closest is 6 months. That you can take or you can, but 1 year for MEN2B it is 1 year. For MEN2A it is 5 years. Prophylactic thyroidectomy. In MEN2A, so if it is MEN2A it is 5 years, if it is MEN2B it is 1 year. Thyroid carcinoma associated with hypocalcemia. So hypocalcemia is not seen even though there is elevated levels of calcitonin. So this question is wrong. Medullary carcinoma thyroid arises from parafollicular C cells. Biopsy from a mass in front of the neck revealed parafollicular cells. How do you follow up? The tumor marker is calcitonin. So you use calcitonin. So thyroglobulin is in differentiated thyroid cancers. Treatment of medullary carcinoma of thyroid is surgery. If it is given advanced malignancy or metastatic, then you can consider radiotherapy also. But if the question is only medullary carcinoma thyroid, then go for only surgery. Needle biopsy of a solitary thyroid nodule in a young woman with palpable cervical lymph nodes on the same side demonstrates amyloid stroma. So, if there is amyloid stroma and biopsy is showing parafollicular C cells, then straight away it is medullary carcinoma thyroid. In medullary carcinoma thyroid, tumor marker is calcitonin. After thyroidectomy for medullary carcinoma of thyroid, which is important for determining the recurrence of the tumor. So I already told, if calcitonin is not there, the next option is CA. The expression of the following oncogene is associated with high incidence of medullary carcinoma of thyroid. It is red proto-oncogene. A 26-year-old woman presents with a palpable thyroid nodule. Needle biopsy demonstrates amyloid. A cervical lymph node is palpable on the same side as the lesion. The preferred treatment, there is 70% of patients presents with cervical metastasis, that is lymph node metastasis. So removal of the involved node, the isthmus, a portion of the opposite bone and the enlarged lymph node? No. The removal of the involved lobe, the isthmus, a portion of the opposite lobe and the enlarged lymph node? No. It is always total thyroidectomy. Total thyroidectomy and modified neck dissection on the size of the enlarged lymph node is correct. So irradiation is in advanced cases and not used for usual cases. Amyloid stroma is seen in medullary carcinoma. A patient has pituitary tumor and pheochromocytoma and a thyroid nodule. Which carcinoma it is most likely to occur? So rather than pituitary, we can take it as a parathyroid adenoma and pheochromocytoma. So these two are seen in, and thyroid nodule, that is MTC, medullary thyroid carcinoma, it is MEN2A. So the question is, what is the other component of MEN2A syndrome? So the other component is medullary carcinoma. A 52-year-old female patient presents with symptoms of pheochromocytoma. She also has a thyroid cancer. Her thyroid carcinoma will be medullary. MEN2 syndrome is seen with following type of thyroid carcinoma, it is medullary. Serum calcitonin is a marker for medullary carcinoma. Treatment of choice for medullary carcinoma of thyroid is always total thyroidectomy. All of the following are helpful for diagnosis of medullary carcinoma thyroid, except spindle cell stroma with few follicles, yes. Amyloid deposition, yes. Calcitonin in stroma, yes. Histological mitochondria is essential for the diagnosis, no. It is always only amyloid stroma and the parafollicular C cells. Mitochondria is more commonly seen in parathyroid adenomas. Which of the following gene defects is associated with development of medullary carcinoma of thyroid? It is red proto-oncogene. Commonest presenting complaints of medullary carcinoma thyroid is diarrhea. Which of the following is true about medullary carcinoma? Calcitonin is not a marker. No, calcitonin is a marker. Arises from parafollicular C cell, it's correct. Produces PTH, no, it is calcitonin. takes up radioiodine? No, it is not arising from follicular cells. So the correct option is B. True about medullary carcinoma of thyroid. It has good prognosis. No. It's associated with MEN1. No, it is MEN2. Increased calcitonin is not associated with hypocalcemia. Yes, this is a correct statement. Treated by near total thyroidectomy. No, it is total thyroidectomy. The option is C. All are true regarding medullary carcinoma of thyroid except it arises from C cells. Yes. It secretes high levels of calcitonin. Yes. It is dependent on TSH. No, it is not a follicular cell, so it is not dependent on TSH. Most cases are familial. No. Most cases are sporadic. This question is a bit wrong. So if the option is most cases are sporadic, then the option will be C. Which of the following does not take radioactive iodine? So only medullary CA does not take up radioactive iodine, whereas these are considered to be the differentiated thyroid malignancies. So they take up radioactive iodine. Calcitonin is a marker of medullary carcinoma. Medullary carcinoma thyroid, it's a repeated question. Red proto-oncogene is associated with development of medullary carcinoma of thyroid. Yes. It can also cause paragangliomas. Yes. So both the options can be correct in this question. Thank you.